All right, welcome back everybody and welcome to the session, The Future of Flex. John Gale from the Flex monitoring team will present on the future of Flex, including the evolution of the program, how we can repair the foundations of rural health, and addressing the changing needs of critical access hospitals. Content will include policy history, addressing hospital closures, and opportunities for improvement. At the conclusion of this session, participants will be able to recall root causes of change impacting Flex programs across the country, understand strategies applicable to Flex that will strengthen the structure of the state programs, and process the steps needed to create regional planning systems to improve the delivery of essential and specialty services in rural areas. John Gale is a senior research associate at the Director of Policy Engagement at the University of Southern Maine's Maine Rural Health Research Center. He has 24 years of experience in rural health research and 16 years of experience managing primary care and behavioral health practices. His work concentrates on rural delivery systems, including rural health clinics, critical access hospitals, community engagement and community health needs assessments, mental health, substance abuse, primary care, EMS services in Maine, nationally and internationally. Underlying his work is a focus on engaging rural communities in building delivery systems that meet their priority needs, efficiently use scarce local resources, provide equitable access to resources to ensure health, and are sustainable over time. Mr. Gale is the immediate past president of the National Rural Health Association. So with that, John, I'll turn it over to you.
Thank you, Nicole. And I'm going to pop my slides up. It's such a pleasure to be with you all today. I've worked now with the Flex program probably as long as anyone who is still not retired. Terry, I'm sure, has beaten me by a bit, and a few others, but I've been with the program for a long time. And so what I wanted to do today was to, as we move into the future of Flex and we think about it, is sort of give you some of my thoughts on what has evolved and changed over time, where the program might be going, where critical access hospitals and some of the issues that they're facing. And then some feedback from some interviews that we've done and focus groups on thinking about the future of Flex for the next competitive cycle. So this is going to be sort of a broad take on this. Some of it is really my own opinion, but hopefully it's an informed one. So I'll share with you some of my team members that have been on the focus groups in the Future of Flex project that we're doing this year. Sarah Contraster and Celia Jewell are the two other researchers on this project with me. And as Nicole mentioned, we're going to talk a little bit about the evolution of the Flex program, thinking about what's happening and what has taken place in the environment that impacts rural hospitals and critical access hospitals as we move forward, thinking about, you know, it's interesting. And I will say I've come to this conclusion after a bit of thinking about this, is that we've had, since I've been doing this, multiple rounds of critical access hospital and rural hospital closures. And the reasons for the closures have been shifting over time. And I think it's important to understand this. If we don't remember the history, how we've gotten to where we are, we're destined to repeat some of the mistakes. And then we'll summarize the focus groups and talk a little bit about the opportunities to move forward.
Hey, John, this
Yes.
is Nicole. Do you want to maybe make your slides full screen so everybody can see them a little bit
Sorry,
better?
my mistake. I thought I'd done that.
Looks good. Thank you.
So I put together an article with two of my colleagues from NORC that you all know, Sheena Popet and Alana Knudsen. And early on during COVID, and we really wanted to look at what's going on. And it's been my opinion that COVID has not necessarily changed added new problems to the rural health system, but it certainly exacerbated everything that we've been struggling with for years. So we have increased risk of closure. Most of you have heard these statistics. 181 rural hospitals have closed since 2005. Somewhere around 450 are at risk for closure. And of that, 200 approximately are considered to be at high risk for closure. And some of the reasons for that are we have payment policies that are ill suited to low volume providers that became increasingly problematic during COVID as hospitals had to postpone and shut down non-essential services, and they didn't have any capacity to make up for that. We've had low investment in population, public health, and primary care. Our workforce is increasingly maldistributed across urban areas and to lesser extent in rural areas. Workforce is probably going to be, I predict, the biggest challenge for the future of the FLEX program in the years to come, of certainly the future of critical access hospitals. We have low patient utilization, and we're continuing to see a decline in rural communities and resources. So one of the problems we run into, and I think this is worth talking a little bit about because I think it provides some opportunities and underlines some of the suggestions that we'll talk about in a bit, is that we're predominantly focused on a market-based system, and we don't have any sort of structured planning to help distribute and coordinate services. So the market-based system puts us in a bit of a bind. It inhibits coordination. It promotes wasteful competition. We've all been in communities where we have 2 to 3 safety net providers all struggling for patients. And then a commercial payer may come in, or a commercial company and vendor and provider come in and sort of peel off all the more affluent and better paying patients. It distributes services inefficiently. And one of the things that I think it's really important and worth looking at is that it has shifted planning from local to corporate levels. So during the consolidations of hospitals or acquisitions by nonprofit groups or even for-profit groups, it shifts the planning away from the local community. And it'll be important when we talk about trying to bump up utilization. And finally, our payment policies, as we all know, are just not suited to small providers. It doesn't cover the fixed costs, and it really, most importantly, discourages the delivery of high-value, low-margin services, such as primary care, chronic care, and prevention. And these are the things that we need in rural communities to keep our populations healthy. Bypass. I think this is one of the problems that we all talk about sometimes, but as you think about this within your FLEX programs, bypass is, I think, one of the biggest problems that these hospitals suffer from. If you look at some of the University of North Carolina's COMPASS data on critical access hospitals, on average, the acute census, daily census for all critical access hospitals across the country is somewhere around 2 patients a day. Perhaps maybe a couple of additional swing bed patients. So that's a model that just doesn't make sense. And so an important thing to do is begin to understand, is there a way of trying to bring some of these patients back? So most importantly, if you look at the numbers, 76% of patients in rural counties bypass their hospital to obtain care. The average is 35% in suburban and 23% in urban. But even more importantly, 60% of that addition, 76, really had they had lower acuity conditions that could have been addressed by their local hospitals, but they still bypassed them. And so thinking about how to work with hospitals and help them to think about that's going to be critical. It really talks about, I think, a tension between the desire to save hospitals and their local responsibilities. I recently read an article that talked about NIMBY versus NUMBY. And NIMBY is, some of you may have heard the term, it's not in my backyard. People don't want a drug treatment center, a halfway house, wind farms, whatever you want to think about in their backyard. But NIMBY is not out of my backyard. And it talked about these efforts that community leaders have to try to keep those hospitals. But part of it means having a real conversation about what it means to keep a hospital, that there has to be some level of community support. And so here are the strategies. Traditional support policies are important. We should continue with them, but they're not enough to fully repair our system. And I think we're in a situation where we continue to promote the same policies without thinking about being transformative and innovative. We should continue to try to build our workforce, but all the data tells us we're not going to get a sufficient number of primary care docs and other providers in rural communities. So how do we transform that? By making service delivery more efficient, perhaps rebuilding, using technology, using team-based care. So I really think that we need to think much further outside of the box than we do. So here are some of the things that I think we're talking about. New financing delivery models. We are seeing that with the Rural Emergency Hospital. Community engagement, to engage them, and local health planning for that matter, to engage them in building the systems of care that they can use and support, and thinking about regionalizing delivery systems. So I'm going to see if I can get rid of this. Hold on a second there. So if we think about I want to go back and take a little bit of a walk down memory lane on the policy history for rural hospital initiatives, because I think, excuse me, we're in danger of losing some of this perspective. Is this concern about rural hospital closures is not anything new. It goes back as far as 1965 when we implemented Medicare and Medicaid. And the first time that we began talking about this idea of a limited service hospital, which was how we originally described critical access, was back in 73 when rural hospitals couldn't meet the conditions of participation from Medicare in terms of staffing and those sort of issues. And then since then, we've had numerous state and federal programs that have responded to changing waves of closure. Going back to the 80s, the Montana Medical Access Facilities, which rolled into late 80s, early 90s into the Essential Access Community Hospital, Rural Primary Care Hospital demonstration, which we call the Each Peach. And then finally, that got rolled into the Flex program. And so we're now going through, I think, another round of closures, and we've got to think about what we do next. So the waves of closures I mentioned in the 70s was wrestling with the conditions of participation. There was an effort to define changing conditions of participation for what were called limited service hospitals. That name really upset a lot of folks, so it never got off the ground. But importantly, it created DHEW, which was the Department of Health, Education, and Welfare, the precursor to Department of Health and Human Services, funded a report that looked at limited service hospitals, but created a situation that has set the stage for all efforts to support rural hospitals, certainly MAF, Each Peach, and critical access. So it defined the roles of the states in developing rural models. It established this concept of a limited service model. They used 30 minutes of drive time to distinguish isolated facilities. In the subsequent demonstrations, it became a 35-mile travel distance. And it attempted to balance regulatory relief and payments on service capacity. The 80s was our next round of closure, and that really dealt with the implementation of the prospective payment system under Medicare, which did not work for low volume hospitals. And so PPS came on board in 83 and rekindled this interest. And the states, rather than the federal government, led the way in the 80s and 90s. And so there were models like the limited service model, which we saw in a number of states, Montana being the one that really caught some traction. alternative licensing standards and alternative models, including things which eventually showed up in the Frontier Extended Stay Clinic demonstration, FESC, and in Kansas, a model that has been the foundation for the Rural Emergency Hospital. So MAF was conceptualized in 85, developed through an 87 demonstration grant. And the waivers took place in 1990. And when we started going into the 90s, there were a lot of things going on. So it was about payment, but changing market forces, utilization patterns, managed care, commercial payers, and a really sort of tumultuous healthcare environment. As I mentioned, Each Peach came along in 89, got off the ground in the early 90s with 7 states. It took a while to get it up and running, but by the 90s, we saw another range of closure that expanded, which became Flex and the Critical Access Hospital Program. Now, as I think, I want to take a moment and actually think a little bit about some of these things that may be different. That we don't think about. We saw the decline in the 80s of federal health planning. We instead allow the market to make decisions where the commercial system sees opportunities. And what that has done is create a competition in rural communities, sometimes wasteful competition, sometimes it's good. Managed care came along. And we're also seeing different utilization patterns. So as we've moved, the need for inpatient beds from the early days of Flex and MAF and Each Peach has changed. We're doing much more out of the hospital than we ever used to. And unfortunately, what we've done with Flex and some of the other programs has really stayed on that inpatient care side and enhanced payment using inpatient services, which I think is creating some of the problems we see now. So as we've moved along, we are now seeing some state level activity. 2 models that we'll be studying a little more is the Georgia Rural Hospital Stabilization Program, which is a hub and spoke model, Kansas Primary Health Center model, which was the foundation for the Rural Emergency Hospital. We've got the federal demonstrations for new payment models. The REH, the Pennsylvania Rural Health Hospital Model, Rural Health Model, the Vermont All-Payer Accountable Care Organization, and the chart, which many of you are familiar with. And so what we're seeing is that COVID has sort of taken what was a very tumultuous, unstable market and environment for our hospitals and just really widened the cracks. So 19 hospitals closed in 2020. The record previous to that was 18 in 2019. So I think we just need to begin to think differently about this. I'm going to take a moment, talk a little bit about the future of Flex focus groups. And we appreciate all those who participated. So we just really trying to get a handle on what hospitals need, what our stakeholders, including folks and our partners from TASC, the Resource Center, Arquita, and others, the American Hospital Association, see as the need for CAHs. And then we interviewed 2 rounds of state flex coordinators. So as we look at this and we think about it, we had a CEOs, CFOs, CNOs, and quality improvement staff. So as we have been thinking, these folks thought that MBQIP in particular was a bit too focused on inpatient issues and doesn't meet the largest service mix of CAHs on outpatient care, ambulatory care, swing beds, and long-term care. We also heard from them that they are having to report different quality data to Medicaid and commercial insurers. And the question was, can these reporting requirements be aligned? I think that's worth exploring. Workforce is at a crisis stage for many between getting enough docs, the nursing staffing services are an incredible issue and challenge for our hospitals. They have financial concerns about expanding service lines and building specialty telehealth capacity. Long-term care is an issue. Swing beds are often filled with patients who have moved to a different level of care and they're paid at a lower rate. And then population health. We know a lot of our hospitals understand that there's a role for them in population health, but I think they need some support in thinking about how they do this within the context of their mission. You know, we too often, when we talk about population health, the social determinants, now health equity is falling into the same mix. We do it at a very high level, and hospital administrators will tell us they can't fix poverty. They can't address food insecurities completely, but they have a role that they can play in collaboration with their community partners. And I think that's important to understand. So what they wanted for flex support from CAHs, they appreciate the ongoing ability to network and create conversations between their peers and other hospitals in the state. They wanted more education on ACOs and key elements of successful CAHs, and critical access hospital and rural health clinic interactions. I think that's important, as we'll talk in a bit. The focus of our critical access hospitals and our systems of care in rural really needs to strengthen the focus on primary care and a little bit away from the specialty care. They enjoy the regular sharing. I know many of you will have quarterly meetings and regular meetings of peer group for administrators and quality staff. Now, one of the things that we heard too was the importance of the training that you all do especially for new staff. They have such turnaround and such turnover, I should say, that they lose some of that capacity. And when a new person comes on board, there's a need to help support them and bring them up to speed on what Flex is doing. The Flex partner focus groups, some of the same things. They think primarily the main program areas work, but there's room for adjustment. One of the conversations that they or the thoughts that many of them shared with us is that the breakdown across the program areas and the activity areas within the programs, there's a fair amount of overlap. So it's hard to know exactly where things fit within quality improvement and financial and operational performance improvement. And the challenge is finding the right balance between program structure and performance within each state, and the desired flexibility to better meet their needs. And this is a theme that's not new to any conversation that we've had within the Flex program. And we've heard it before. But it's worth exploring that and thinking very seriously about it as we move forward. The partners thought that providing some structure was particularly useful in certain situations. MB-Equip was an example because it was able to guide and direct Flex activity and staff members who were knowledgeable about, who didn't have staff, I should say, excuse me, who weren't knowledgeable enough about the program. So it gave them a little more direction, but they still feel the flexibility is important and that we need to sort of get a handle on and define some of those issues. Needs of CAHs, workforce, staff burnout, retention, and frequent turnover. They like the learning communities. Examples include South Dakota's EMS Case Review Network or the University of Washington Technical Assistance Program. They thought highly of leadership programs, training on strategic agility and resilience. They underline the importance of pipeline programs to encourage the development of moving students into health careers. Team-based care is something that they were interested in. How do you create situations that make the best use of scarce local resources and get everyone working at the top of their licensure status or certification status? They also thought that some core fundamental training that could be done on demand and videoed would be helpful as they talk about turning over staff and understanding what MBQuip is for a new quality improvement coordinator, that would be helpful. And then finally, working on financial stability and sustainability. They thought it was important to mine the CAH financial data to identify opportunities for improvement. And they really liked the idea of working with groups and cohorts of individuals in a few key areas. They like the structured pathway for CAHs to apply flex educational materials. How do they implement what they're seeing? One of the capacity issues was around leveling the playing field on electronic health records and efficient reporting. They thought there was a need to sort of focus on frontier hospitals and at least create an opportunity for them to work together and network employee safety, patient safety, and survey readiness. And on the EMS side, really, this is where they thought program structure would be helpful, starting with a statewide needs assessment to identify gaps and solutions, and then begin to move away from help to convert from volunteer to paid status. So I think these are going to be significant challenges and worth thinking about. Not easy solutions, by the way. And program structure, again, MBQuip, which had a very important role in bringing some consistency to critical access hospital quality reporting, but they highlighted the need for change and to perhaps figure out how to adapt to other areas of activity and services. And then the offsetting challenge to that, of course, is how do we get measures that are consistent and can create a national picture of the quality of CAHs. Their focus included swing beds, which I think is really important, the ED caps, and other patient and family engagement measures. Ambulatory care was critical since that's the primary activity where patient care takes place. So these are some of the basics. I won't go over all of them, but I think they're important to examine. And then we'll go into, and here's one point, and Tim Size was an advocate for this on the panel. And Tim, I think, is one of the best rural health thinkers in the country. And I think this is where I think some of the challenges and opportunities take place. How do we modernize the hospital? Modernize flex by rethinking the hospital. Much of our care is in acute care, so it's no surprising. I think the big services are acute care, primary care, swing beds and long-term care, perhaps some rehab and that sort of work. And so can we begin to think about providing some structure that keeps the hospital as the hub? You know, the rural emergency hospital, I think, will be interesting to see. And I think it's important to recognize, I know there are some skeptics out there about whether this is the right solution. But if you think about some of our other federal programs, it took a while for critical access hospitals to catch on. It took even longer for rural health clinics. So I don't think we want to write off the model yet, but understand there may need to be challenges. There may need to be adjustments and revisions as the program rolls out. But can we think about other ways of keeping that facility so that the hospital is the hub of care without relying primarily on inpatient services for funding and enhanced payment? Focus groups, some of the same issues. They recognize that CAHs have competing demands from different payers. How can Flex help to sort of minimize that conflict across payers? Not much new there. They love the idea of outpatient QI measures for rural health clinics, which we've worked on for a while, swing bed and long-term care measures, population health. Many are interested in things like Pennsylvania's rural health model and value-based purchasing. but they felt the need for some clarification on how to work with with hospitals and flex program areas. They'd like some clearer direction from FOHP. I had a transposition there. I apologize. That expects what can hospitals do, and I'll talk about this in a bit. Look at EMS. So there was concerns that excluding trauma from EMS and placing another under a different program area didn't make sense. And there was some discussion around the innovative models, whether that should best be maintained as a separate program area or whether it could be folded into one of the other 4 program areas. So again, things to think about. What we know, consistent with what we've heard in the other setting from the other groups, COVID has overwhelmed CAHs, installed a lot of activities, and the hospitals report that they want to get back to the basics. There's a lot of concern about COVID funding drying up, and how do we focus on the essential elements to move forward. A lot of concern about the financial condition of independent CAHs, those that are not part of a system or haven't been acquired, around market share, utilization, charge masters, and the like. And then workforce is a significant concern, and mental health also in rural communities. Needs of EMS, again, transitioning from volunteer to paid staff, education toolkits and technical assistance are required. And there was some real interest in regionalizing services and whether or not training programs targeting the needs of younger people could be used to focus on the workforce, to supply the workforce. There was also interest in sort of working around the application template. Many thought it was a bit of a challenge and didn't lend itself well to planning around activities. So there was an interest in looking at simple questions. What are the goals of the project? What are the methods? What outcomes and what changed? So there's some interest in beginning to make some change with that. State Flex programs identified the need for a more unified, coordinated approach and discussion among all of our Flex partners, including the office, task, Arquita, and the Flex monitoring team. They want to know what works, and that's going to be the critical piece. And then finally, outcome measurement. All of you love this so much, I know, is how do they would appreciate some additional help to work with their consultants. Is there technical assistance that can be provided? And how to do that. So one of the things that we heard from them is that many of them asked for additional technical assistance. Now we know Task is providing TA, the Flex monitoring team, Arquita, and a variety of players, but maybe it's worth going back and thinking about. So this exists, is it because people don't know what's available, they're not taking advantage, or is there something that's not being provided that we can identify? So it's worth exploring all of this. So here's where you'll get some of my opinions around how to move forward and think about supporting CAHs and EMS. The peer interactions between CAHs, the sharing of information, the convening of peer grouping and networking opportunities are critical. I think this is an important foundational element of Flex, but I don't think it's enough on their own to really support CAHs. So thinking about, what do you do as part of your day-to-day activities, but then what are the specific things that you can do to enhance Flex performance? Some of it's building capacity. I don't think it's often, I think it confuses people when they think about this. You always have to show that there's some significant improvement. But if you have problems, so one of the things we hear an awful lot is that the EHRs are a problem. If you talk to physicians, the electronic health record is the biggest driver of lack of satisfaction among providers. So if you can build some capacity issues in terms of being able to use data, maybe improve performance around the use of the electronic health record, drive its use for quality financial and population health data, that's great. And I think that's really an important part to look at. Providing some of that leadership training that everyone needs. I think moving away from individual single hospital projects to cohort-based initiatives makes a lot of sense because you can then leverage resources. I think it's important to look at common activities that are needed across cohorts of CAH and focus less on some of the process-oriented activities. And when you do process-oriented activities such as needs assessments, readiness assessments and the like, they're part of the starting point of activities, not something that should be repeated year after year. Some of the policy options, and this is where it starts getting tricky. Payment reform is necessary. How do we uncouple payment from fee-for-service payment so that we can cover fixed costs, support population health, and allow for the improvement of essential services? And this is going to be something that you can't do at the state level, but I think is going to be an important issue. One of the ongoing future trends as we move forward, it's not new, but I think it's going to gain traction in the next 5 to 10 years, is the need to control costs. We're now, for the US health system, at 20% of GDP. And so there will be payment reform designed to control costs, but it probably won't recognize the importance of rural healthcare and the fact that the costs are going to be higher in rural communities. So we're going to have to be alert to protecting our rural providers and critical access hospitals as payment reform takes place, so that we can acknowledge that. We're going to need to think differently about models of care. To provide essential services. Technology is going to be critical, but it's a lot more than just telehealth. I think we have to think about how we use telehealth as one option, perhaps artificial intelligence based on evidence-based guidelines to really reform how we provide care. If we're not going to be able to get enough mental health providers, and we're not going to be able to get enough primary care docs and providers in rural communities, how do we use them better? And I think this is going to be something that's really worth thinking about. We need health planning to offset the flaws in the system, to manage the problems that take place due to the market. And we really need to think a little bit about regionalizing services. So I will take an opportunity to discuss, and I've got a few more minutes, so I'm just about done, to talk about regionalization, because I think this is an essential issue. OB and maternity care is probably the service area that's getting the most attention in the policy environment today. It's important, it's an essential service, but many critical access hospitals, and if this is my opinion, and I don't want to talk for anyone else, shouldn't be doing much of maternity and deliveries. They're not doing enough of them to be good at it. They don't have the specialty backup. Many of the primary care providers, who are the basis of their local system, are not really that interested in doing OB care anymore. So getting enough obstetricians and specialists back into rural communities is not going to happen. Instead, what we do is we need to think about regionalization, getting together a group of hospitals that might be willing to talk to one another about selecting one hospital as the center of excellence, doing the deliveries at that hospital, and then building out the capacity to do all the other services that pregnant women need for their maternity care. So we do all the prenatal and postnatal care at the local level. We do all the diagnostic work, and then then deliveries at one hospital. I'm not naive. If you get 5 hospitals together and tell them one's going to do the deliveries, they're all going to fight for it. So we're going to have to figure out that problem. But I think we can do the rest of it. So and this holds true for specialty care, surgical care, mental health services. How do we think about creating a more efficient network that allows the services to be developed? And in the case of OB care, If transportation to a remote delivery site 35 miles away is a problem, part of what we do is deal with that transportation issue. If part of the problem that we get into is childcare for children, for mom and dad to go to the hospital, we can deal with that. So we just, again, need to be more creative than we have been heretofore. So closing thoughts. I think we need tools and resources to support rural communities in taking responsibility for their health systems. It's not okay for a community leader to tell us they want to maintain those hospitals, keep it in place. We don't want to let it close when they're not willing to provide some support, either financially, as we see in some publicly owned facilities, municipally owned or county owned. Or how do we even think about utilization? That's going to be the problem. I think states can begin to look at regional planning systems to improve delivery of services and to offset the flaws in market-based systems. The new delivery system models, thinking about what we need and how we do that. I mean, the only challenge I see with the REH is that it does away with inpatient beds, which may be good in some areas, but certainly not in all. So how do we move away from the payment for the inpatient beds? We use technology and we become more innovative. That, I think, is the end of my slides, and I'm open for questions if any of you have them.
Sure. Thanks, John. I see we did have one question in the chat.
Okay.
And so from Dorothy in New York, she said, in regards to pipeline programs to replenish the healthcare workforce, do these programs also target adult workers making career changes, such as accelerated nurse practitioner programs geared towards older workers with bachelor degrees? She also said, depending on the state, nurse practitioners have also have almost as many privileges as MDs. So that path would be more attractive to career changers than pursuing a BSN.
I completely agree, and they should do that. Whether that can be something done efficiently in Flex is another question, but I think you're right. Pipeline programs traditionally targeted high school and college students, but I think in the workforce, if we can begin to train, a number of universities now have what they call their advanced nurse practitioner programs. They have their occupational therapy and others. So yeah, I think you're right. I would agree that those pipelines need to be broader than we traditionally have made them.
There was another comment in the chat from Pat Justice in Washington. She said, our CAH CEOs believe that they take a big hit on the cost reports if they own EMS, home health, and behavioral health and want this modernized. She said they had 3 hospitals work on regional solutions, but OB is a negative drain on finance, so they fight over who has to take it.
There are 2 ways of looking at that problem, but Pat, I completely agree. And that's the challenge we face moving forward, is how to revise payment strategies that make sense. How do we undo some of the regulatory burdens? But I think that's right. We don't need as many inpatient beds in rural communities, but the issue isn't whether we close the inpatient beds, but how do we create a model that focuses and pays for the services we need and provides that support, covers the fixed costs, provide emergency response capacity. That's going to be the challenge. And I think also in light of probably what's going to be, I think, a growing emphasis on cost control, our rural providers and rural critical access hospitals risk being left behind because they're by default. They're not more expensive. Efficiency is a funny thing. They're never going to be as efficient as a larger hospital. So I think we really need to have policy makers focused on that, because that's going to be an essential issue for the future.
Great. Okay. So I don't see any other questions in the comments. I think we'll go ahead and wrap this session up. So now we are going to be placing a Zoom link in the chat box. We will continue with small group discussions about the future of the Flex program. So please click on that Zoom link and we'll see you there momentarily.
Thank you.
Yeah, thanks, John.